Okay. There it is. All right, that should be good. So, again, I'm Nate Wilborn. I'm the founder of Precision Genetics. Been in the healthcare space going on 2 decades. Prior to that, I was a professional basketball player. A lot of that's where that picture came out. It just got done playing and was in pretty good shape. I've had 7 surgeries since then. So, we founded Precision Genetics. We got in the molecular diagnostic space. When I first got in the space 5 years ago, it was really centered around applying innovation and technology towards the molecular world. If you look at the molecular diagnostics world, is looking at someone's genetic infrastructure to determine how to either diagnose properly, diagnose more effectively, or more importantly, treat more effectively. So we look at your genetics to determine what's the best way for us to treat you once something happens, an event or an occurrence happens, diagnosis related. We can look at your genetic profile to determine here's how you should be treated. This is what medications you'll process properly. These combinations of medications could potentially be risky for you, and how do we address those? So our target market, if you look at the way we target or we treat people in the United States, 82% of our population takes at least one medication. That's a staggering number. 50% of the meds that are prescribed are ineffective. And we are really focused on the employer space specifically. 1 in 3 self-insured employers typically suffers from at least one chronic disease. It's now the 4th leading cause of death. Adverse drug events are now the 4th leading cause of death. And healthcare has become the number 1 reason for bankruptcy in our population. So what we're focusing on is the employer space. What we want to look at is their trend for healthcare cost, if you're self-insured right now, is about 14% is what they're spending in growth on the cost of pharmacy and the cost of healthcare over each year. So the problem with that is, 1, it's not sustainable. 2, it's a substantial amount of spend to treat their people. And what's the worst part about it is we're treating them ineffectively. So what we've done is we've developed a targeted genetic platform that is centered around the self-insured employer. It's also focused in the perioperative space. So we have a substantial amount of IP and development around panels to look at, like if you're going in for surgery, how do I look at your genetic profile to determine preoperatively, intraoperatively, and postoperatively, how am I going to treat you as the anesthesiologist? How am I going to treat you as your specialist? And then what happens to you once you're discharged from the hospital? How does all this surgical toxicity that I put in your body for a 2 or 3 hour procedure impact how the other diseases you're dealing with? So if I'm hypertensive, type 2 diabetic, hypercholesterol, and I deal with anxiety, ADHD, whatever it may be, you put all these drugs in me during surgery, how's that going to impact me when I'm done with surgery? And could that potentially be a risk for me to have an adverse drug reaction? So we look at your molecular and your DNA to be able to determine that. So that's our market. I'll show you kind of in a minute what the financials look like. But if you look at the world of molecular diagnostics, we have a delay here, a little bit of a delay. It's a world of static delivery. So when you look at a physician who's treating someone, and let's just take a primary care physician. The average primary care physician has 3 minutes at best. You guys all go to the doctor. You're lucky to get 3 to 5 minutes with your doctor, unless you go to MD VIP or a concierge service. You're going to get a couple, and if you do get the doc, if you don't get the doc, you're going to get their PA. So you got 3 to 5 minutes with the provider. Do you actually think that that's enough time for them to really diagnose you properly and, more importantly, treat you? No, they don't have the time. The economics aren't aligned. So they have to do it based on a population. Oh, you're struggling. We got your blood back, or we got your cholesterol numbers back. You're out of whack. First thing he's going to do is, I've got 3 or 4 drugs in each classification or treatment that I'm going to put you on. I'm going to put you on this antihypertensive. I'm going to put you on this cholesterol medication, and let's hope they work. Well, if they don't work, you're back in there in 60 days saying, man, I'm not feeling any better, my numbers aren't getting better, and so now we throw something else at the wall and hope it sticks. We don't have to do that anymore. Unfortunately, the doctors don't have the time to do proper diagnosis. Our software was generated to take a molecular diagnostic analysis, do predictive risk assessment on the individual, and then drive it to the person as opposed to all of us in this room. So if we're all on the same hypertensive medication, the odds are a third of us aren't getting any benefit. That's the reality of the world we live in, and maybe higher depending on certain drugs. So what Precision Genetics has developed is we have an interactive tool that we give providers or wellness providers or nurse practitioners who represent self-insured employers. And we now have a guideline that I can interact with this in real time, get into a software that in a matter of minutes or seconds, I can have a physician look at me, the individual. He has a genetic profile on me, which is extremely complex data when you're talking about genetics. I don't know if we have any physicians in here. Are there any physicians?
No. Not today.
Okay, if they're
Not today.
from a physician's perspective, when's the last time, Doc, that you took a core genetics class? Well, if I ever took one, it was 25 years ago in med school. So this data then is almost like hieroglyphics. So, but this is organizing that complex genetic data into a delivery way and say, here's what you need to know based on this person's metabolism, how they're going to process what you're thinking about putting them on. So there are caution flags, and there's genetic pathways on drug interaction with the genetic pathway, drug-to-drug interaction. So we've organized this in a way that the doctor can ultimately drill down to the most important part. It's show me the risks based on the medications. So if you look at this, we have the most frequent side effects associated with a drug regimen. This is a polypharmacy type scenario where you've got a patient on 5 or more medications, an elderly female in this scenario. When I hide the genetic data without the genetic analysis, you can take drugs like Plavix or Lipitor, Zofran, Dilaudid, and they look relatively low risk when you don't have their genetic profile in there. But when I add the genetic profile and I hover over Plavix, this is a this is a decision support stating stop, which basically is telling me as the provider, this patient will get no clinical benefit from the drug Plavix. It's no different than giving them a sugar pill, but without their genetics, you don't know. And so what we're able to do is to make this a real-time tool that we can train physicians or those primary caregivers to stop guessing and cater the regimen accordingly. And once we've identified where those risks are, and there's risks associated with genetics, there's risk with drug interaction, there's risk with age based on the population or the health of this individual, there's lifestyle factors that we take into play here, and then we publish all the clinical evidence that supports those risk factors, and now the doctor doesn't have to figure it out on their own anymore. The human brain you cannot calculate all these combinations of medications in real time. It's not possible. So the tool does the work for them. So from there, they say, okay, you've identified the risk. I know that this patient's not a good metabolizer of the drugs that I've got them on. What do I do instead? And so we allow them to go into an alternative selection at this point. Let this load. It creates my baseline of drugs. It shows me my risk analysis. So for a drug like Lexapro, which is a very commonly prescribed antidepressant, there's genetic pathways that are causing potentially bad metabolism here. I then go into that drug, I pull the database for other antidepressants, and now it pulls every drug within that classification of medication, and it breaks it down by risk, and more importantly, it breaks it down by cost. So now I'm driving cost savings for the individual and the plan or whoever's covering that patient, and I'm improving the overall quality of care. So I'm essentially got a product for the first time I've ever been in healthcare that can impact the entire continuum of care. The provider, the patient, and whoever's responsible for paying for that care. And that could be the insurance company, but that's why we focus on the employers, because 65% of our national spend is covered by self-insured employers. That's a massive number on a $2 trillion spend. So we're going after the low-hanging fruit. It's because what we're able to provide that employer is to say, let's put together a wellness initiative that actually uses targeted genetic therapy, and then let's drill down care plans and create proper care plans on how you treat your employers or your employees and their covered lives. And now we're improving the quality of my employees. They miss fewer days at work. They're more productive at work. They feel better. Happy. It's kind of like happy wife, happy life, right? If the employee is feeling better, then they're performing better. And ultimately, at the end of the day, though, we save them money. So we cut their pharmacy spend down. We get the drugs. We create or eliminate redundancy of medications, and then we give the right care plan for the individual. Once we do that, the economic impact is we're seeing in the neighborhood of 10 to 25% reduction in the annual pharmacy spend once we implement the program. And then we have to drive engagement and enrollment for the people. The elephant in the room anytime you talk to an employer is, if you employ me and you say, hey, we're going to do this new genetic wellness initiative, first thing I'm going to say is, why are you taking my DNA? What do you need my DNA for? What we're doing with that DNA is we're looking at how to treat you most effectively. will never share that DNA back to your employer. There are laws that protect you. So there's the GINA laws, which are the Genetic Information Non-Disclosure Act, which essentially states that once we've got your genetic data, even though your employer paid for it, we can't share that back to them. We can provide it to your doctor or whoever treats you, but that data never gets shared with your employer. And what happens is now we deploy resources to help, improve that care for that individual or that loved one that that's having problems. So that's how the technology works. And I've literally have had doctors change the way they practice. It's extremely effective in pediatrics, as you can imagine, putting an 8-year-old or a 10-year-old on an SSRI, which is a very potent, essentially a mind-altering drug, can be devastating if it's wrong. And so this becomes a better way to do it. The second way we're getting doctors to change is we have an entire perioperative solution. It allows us to take the pharmacogenetics, the genetic guidelines. We incorporate that into genetic markers that look at opioid dependency. So I can test everybody in this room and tell you if you ever had to have surgery, 8% of us in this room on average are going to have a genetic marker that's going to have a higher probability that I'm going to have an opioid addiction problem. So we're taking that genetic data, we're checking genetic data to be able to look at how do we avoid complications post-surgery to eliminate the events that cause readmissions, which are huge cost ticket items for whoever the responsible party is. And then again, now we're getting doctors to have in the anesthesia world to be able to hand back off to whoever that primary caregiver is. Now they've got that genetic data for life. It's a one-time test, and depending on what we test for, it's a one-time test and it gives you a roadmap on how you treat people. So that is our solution as far as the technology and the innovation behind it. We are in hyper growth mode right now. As JP mentioned, we're closing a $1.5 million seed round.
Can I ask you a couple of questions
Sure.
on the business model?
Sure.
Right, so you are providing them the genetic, you are doing the genetic test yourself, or are you?
We own the laboratory. I own the laboratory.
Oh, you own the laboratory?
Yep.
Okay. So you are doing that and you are providing the software to do the evaluation. Is that what it is? Okay.
Yep, so we provide that. Then we also provide clinical resources back to who those providers are. Employers oftentimes will have a wellness clinic on premise, depending on their size, and they'll have a nurse practitioner or a provider that they're encouraging their people to get before you go to the urgent care or the doc in the box, go to your wellness clinic because it saves the employer money.
Right.
And then what we want to do is capture either in that annual physical or, depending on if there's a disease or something that takes place, we want to capture that genetic test at that point and then provide those results back to whoever that treatment or that caregiver is. And so, yeah, we do own the laboratory. We have the rights and exclusive rights to the software, and we're tied to one of the largest molecular institutes in the country. But we're just trying to keep up with the growth.
And this company is to do the software, not to the laboratory, or is it both together?
The company that provides the interpretation data, the institute, is only for the genetic data. The laboratory is ours. It's a commodity at the end of the day. You can put a laboratory anywhere.
Okay.
It's the solution and the delivery back to the providers that makes the difference. So right now, like I said, we're closing. Any other questions on that? Is there any questions before I talk about
the software?
We do.
Oh, okay, I thought there was a.
No, there are institutes that have molecular databases. Like we pull data from all sorts of resources.
Okay.
This is really a data company. We're pulling data, and then we're creating new data on outcomes and evidence-based results that are. Once we change a care plan, now I can track the change in medication. I can change the results. I can look at things like admissions to hospitals. I can look at slips and falls. I can look at total pharmacy spend. I can look at how many days of work that employee missed. There's all sorts of data metrics that we can track to be able to show value savings back to the employer, or it could just be a state health plan. It doesn't matter. We're all struggling with the same thing. It's the overwhelming rise of cost of healthcare. This impacts it and provides quantifiable savings by using that technology.
Are you going to cover customer traction?
Yeah, absolutely. So right now we're mostly regional based. Our primary sources of customers right now are other laboratories that use our services. So we'll do reference laboratory work. So another laboratory that doesn't do molecular testing may outsource that to us and pay us cash for that. We work directly with hospitals, directly with the employers. We work directly with cancer centers and research departments. We call directly on doctors. We're very diversified on our call points. But our focus, because of the scalability, is in the employer space and in the perioperative space. There are 22,000 Joint Commission compliant hospitals in the United States that are, by the end of 2019, have what's called the opioid adherence mandate. So by the end of next year, they have to have a program that does predictive analytics. It does data and outcome tracking on the use of opioids. It's a massive epidemic in the United States right now. Our software just happens to do all of those measurements. We've already been awarded 2 in the state of South Carolina. I fly to Louisville tonight. We're meeting with the 2 largest health systems in the state of Kentucky that cover about 80% of that population. So anything that's healthcare related regarding providers, we touch it. It could be cancer, it could be primary care, internal medicine, it could be orthopedics, it could be cardiovascular. We have data, we have results and outcomes on all those different verticals. But those 2 markets, when we ran the math on the 3 largest facilities in the state of South Carolina, it's north of 10,000 surgeries a month. We're anticipating that if we capture 40% of that, we'll do anywhere from $2.5 to $3 million a month in revenue with 3 hospitals. And there's 22,000 of those nationally that we'll have access to.
Can you talk about your numbers? We've got 9 minutes left.
Yeah, so right now we're averaging anywhere from $50,000 to $75,000 a month in revenue. Our burn is right at about $75,000. We're growing as far as new testing capabilities. We've invested a lot in the technology of what we're testing, both in the cancer markets as well as the primary care and the perioperative space. In July, we'll be doing close to $250,000 to $300,000 in revenue. We really aren't seeking capital outside of my relationship with JP. I don't think we would probably even be sitting here in front of you, but we are closing it. There's a small amount available, and then we have some institutional funding sources that we're in the process with. We think we can scale this on a national level and go after percentages of each market share. If we just attack and focus on that employer space and that perioperative space, this can become a very profitable organization.
Do you have any patents that?
No, we don't have any patents. Our patent is basically the rights to the IP in the space, and the other thing that we have is just speed on the market. We're 2 years ahead of the competition.
Yeah, what's your competition?
There's reference labs all over the country that do genetic work, but they do it. I showed you. They give it to doctors in this. This is 30 pages. If you give this to a physician and you say, interpret this data and then make your decision, the doctor's going to look you in the eye and say, get out of my office. You can't give them you don't have time to read 30 pages of molecular data. So that's our IP is that interactive piece that I showed you. Help me show me the risks, back it with evidence, and then give me my alternatives. And that's what the software does. So, like I said, we have 2 contracts that are going live in June that will take us to $250,000 in revenue. We're forecasting in the perioperative and the workplace wellness that the second half of this year we're looking at about a $4.5 million revenue run with about $1.5 million in EBITDA by the end of the year. So at that point, if we want, it becomes a decision how quickly can we scale, and then we'll start looking at some institutional funding sources at that point.
So you have not done your Series A yet?
Not yet. That's next.
When will you do it, do you think?
I would think second half of this year.
Can you talk about your pricing model? Some of this is non-recurring testing and what a test costs. And some of it, I guess, is subscription based.
Per member per month on the data side. We capture setup fees on the employer side. We get a per member per month for every covered life. For everyone enrolls, we typically get anywhere, depending on total number of lives that are covered, we'll capture anywhere from $300 to $600 per test. Again, the higher the volume, the lower that cost comes. From a margin standpoint, our sunken cost of goods on that is relative about $50, including overhead. So our margins at $300, which would be our lowest in price, still relative after commissions are still north of $200 per test. So we're in a very strong financial margin. Again, this is a volume play too. When we ran the numbers, if we capture 10,000 surgeries a month at an average ASP of $400, it's $4 million a month in revenue. That's how quickly we get there.
So to go from 50 to 75, you said you're gonna be at revenue to 250 to 300 in 2 months, is that, did I get
Yeah,
that?
by July.
And then how much of that is recurring revenue and how much of that is non-recurring revenue?
It's probably 80% new revenue, and there's ongoing. It'll be about $3 per test for everyone enrolled. Not everyone who has tests. It's literally every covered life. So if I sign an employer that has 10,000 people, I'm getting $3 a month for every covered life.
So when you say new revenue, I'm not sure, does that mean?
A cost per test. So there's the one-time test for the genetic analysis.
And that's what 80% of it is?
That's it's starting in July. That's what those numbers equate to. But our numbers get better as we add lives over time. The immediate revenue kick upside to us is the cost per test for the if I sign 10,000 and 2,000 enroll, I get 2,000 at $400 a pop. So I get a big kick in revenue, and then I get an ongoing for them in they're 3-year contracts in our program. So our the only thing we've settled for less is 24 months to date. So just to get us to 75 to 250 is just on 2 that are going live as we speak. So, and I've got dozens in the pipeline to follow. So we're in a really strong position. I mean, this company will be profitable within months.
Is this a price round or a convertible note?
This was a convertible round, but at this point, this last bid would just go straight into the shares of the corporation.
Valuation?
On the seed was pre-money of 3, opposed to 4.5. So there's only 200,000 available, and we weren't even going to bring it in.
And this is a different valuation, or it's the same?
Same valuation.
Okay.
What's the class of stock?
It's at common stock.
Oh, it's common stock.
Yeah.
Do the hospitals pay? Did I miss that? Do
Hospitals pay, insurance pays, there's cash pay, there's labs pay. We try to focus primarily in the contract pay because reimbursements can be inconsistent. Medicare just does what they want. It's reimbursable by Medicare, but not everything is. So like I could do a hereditary cancer test on you and pick up a couple $1,000, and then do a pharmacogenomics test on you and get $400, and they could at any day shut it off if they wanted to, or change the rules on how you get paid. So we really focus on the contract pay. That's why the employers are attracted to us, because the employer will pay us the $400 and the per member per month, knowing that we're going to be saving on average. Like our average saving estimate per employee that's in the program is around $1,100 a year. So would you pay $400 to save $1,100? The answer most frequently is yeah. And we'll risk share with them too. If they're big enough and they've got chronic disease, absolutely we'll risk share with them, because now I'm getting a lot more than I'm getting on the per member or on the fee for service.
So I may need to rephrase my question. To doctors that are getting the analysis, is there a software subscription to be able to say, like, all right, you ran the test, now we look at genetic code, I'm prescribing XYZ, and then you showed us the kind of...
So is there an ongoing for the directly to the doctor?
Hospital, whoever it is that's looking at the analysis?
No, it's whoever's paying for that. So
Okay.
it's whoever's, it's the insurance company, the employer, or it's the government. So the payer is the one who we charge, or it could be the patient, right? You know, we have moms and dads that pay for their kids. You know, if you're on a high deductible at $5,000, and you know, for an out-of-network service like what we do, you know, it's a $10,000, out-of-network deductible, and I can charge you $400, or you get an EOB for $3,200. You know, it doesn't take them real hard to figure out. I just want to go ahead and pay the $400 and test my child before you put them on an ADHD medication.
Your software, obviously highly scalable. How is just the lab testing component? I mean, as you just grow, is that a constraint for scale?
No. The software is incredibly scalable. The lab testing is just basically throughput. So let's just say we get to 2,000 tests a week. My current lab with one shift of personnel can handle that volume without any problem. If I triple that volume, so what do I do to scale? I either add an instrument, I add a shift, or I expand my lab. Scalability, it's completely vertically integrated. Our laboratories in Greenville, South Carolina. I have franchise laboratories that we're working on in pockets of the country right now. Other labs that we use our service, it's another way we drive revenue. So if I had an employee or a benefits broker in Dallas, and they're sending to a central location, and I want to just ship it to Houston to my franchise
Yeah.
lab and keep my logistic costs down, I can do it just like that.
So that's not a constraint.
Not at all.
We got 30 seconds. Any other final questions?
You said you own the lab, is it the company or you personally?
My company. The company.
So physicians don't have to install any software or anything of that?
Nope, it can be fully integrated into the electronic medical record. It's all automated.
Cool. Thanks a lot, Nate.
Thanks, gentlemen.